The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast, where we navigate the maze of healthcare policy and economics each week. My name is Marc Ryan, and thanks to everyone for listening in. This week's episode is titled America's Healthcare Grand Bargain, Price Reform, the Missing Piece of Healthcare Reform. Before we begin, if you missed episode 1 of this 5-part series, I encourage you to go back and listen. In that episode, I laid out my overall vision for reforming the American healthcare system. I argued that meaningful reform doesn't require us to choose between government and the private sector. Rather, it requires us to take what works from both. I proposed 3 fundamental pillars for reform. First, rationalize healthcare prices. Second, shift our focus from utilization management to primary care prevention and true care management. And third, create affordable universal access through a uniquely American private delivery model. Today, we're diving into the first pillar, price reform. If you'd like to follow along after the podcast, you can find my companion blogs on the Healthcare Labyrinth blog site. It's the second article in my 4-part healthcare reform series. Many of these ideas also come from my book, The Healthcare Labyrinth, which is available in print, ebook, and audiobook formats. So let's begin. We'll take our usual 3 breaks. Part 1, a simple question. I'd like to start with a question. Imagine you walk into a coffee shop. You order a medium cup of coffee. The price is $4. The next day, you walk into another coffee shop around the street. Same coffee, same size, same quality. This time, the price is a whopping $40. You'd probably laugh. You'd assume someone had made a mistake. Or maybe they were trying to scam you. Yet, that's remarkably close to how healthcare pricing works in America. One MRI might cost $500. Another, performed on essentially the same machine with the same technician and the same radiologist reading the image, costs $5,000. One hospital charges 3 times as much as another for the same knee replacement. An employer in one city pays dramatically more than another employer just a few miles up the road. None of this makes sense, and yet we've accepted it as normal. It shouldn't be. Today, I want to argue something that may surprise you. America doesn't primarily have a utilization problem. America has a price problem. Yes, unnecessary care exists. Yes, fraud exists. Yes, overuse exists. But none of those explain why we spend dramatically more than every other developed nation while producing, at best, mediocre outcomes. The biggest culprit is price. Part 2, the elephant in the room. Healthcare is one of the few industries where consumers often have no idea what something costs until weeks after they've received it. Think about that. You wouldn't buy a car without knowing the price. You wouldn't renovate your kitchen without an estimate. You wouldn't book a vacation without comparing costs. But in healthcare, people routinely undergo procedures worth thousands or tens of thousands of dollars with virtually no understanding of what they'll ultimately owe. That isn't a functioning market. It's the absence of one. The lack of price transparency doesn't simply frustrate patients, it destroys competition. When nobody knows the price beforehand, providers compete less on cost and more on market power. And market power almost always leads to higher prices. Part 3, America's hidden price inflation. Here's something many Americans don't realize. When we compare healthcare spending internationally, Americans don't actually use dramatically more healthcare than people in other developed countries. In many cases, we actually use less. We visit physicians less frequently. We spend fewer days in the hospital. We have fewer practicing physicians per capita. So why do we spend almost twice as much? Because we pay dramatically higher prices, higher hospital prices, higher physician prices, higher pharmaceutical prices, higher administrative costs, higher insurance overhead, higher specialty care costs, higher device costs. Almost every component of healthcare costs more. The issue isn't simply utilization, it's price. And until we address price, we're going to keep asking employers, taxpayers, and families to finance an increasingly unsustainable system. Part 4, the friction called the change master. Now let's talk about one of healthcare's worst kept secrets, the hospital charge master. If you've worked in healthcare, you've heard of it. If you haven't, you probably haven't. Hospitals maintain enormous lists of prices for every service they provide. Those prices often bear little resemblance to reality. They're inflated, sometimes wildly so. Why? Because almost nobody actually pays them. Medicare pays according to its own fee schedule. Medicaid pays according to its own fee schedule. Commercial insurers negotiate discounts. Medicare Advantage plans negotiate discounts. Employers negotiate discounts. Everyone negotiates. The charge master, however, becomes less of a pricing system and more of a negotiating tool. Hospitals often defend these inflated charge master prices by pointing to lower reimbursement from government programs. There is certainly truth that Medicaid reimbursement can be inadequate in some states. I don't buy the argument that Medicare payments are, though. But the results has been a system where commercial insurers and ultimately employers and employees bear much of the burden through cost shifting. The consequence, American businesses pay some of the highest healthcare costs in the world. That's not simply a healthcare issue. It's an economic competitiveness issue as well. I would also note that plenty of studies do show that hospitals can earn a fair margin at Medicare and even Medicaid prices. It is a question, though, of efficiency. Indeed, the charge master system and cost shifting encourage hospitals not to be efficient, but in fact to be bloated. Part 5, why prices keep rising. One of the biggest myths in healthcare is that annual price increases simply reflect inflation. They don't. Here's why. Suppose a hospital lists a service at $1,000 this year. Next year, they arbitrarily increase the listed price to $1,070, a 7% increase. Even if the negotiated rate remains a fraction of the listed amount, the negotiation now starts from a higher baseline. Each year, that inflated starting point ratchets commercial prices upward and onward. Eventually, those higher reimbursement rates show up somewhere. Higher premiums, higher deductibles, higher coinsurance, higher employer costs, higher taxpayer spending. It's a vicious cycle. And because every major hospital system behaves similarly, the entire market gradually moves upward together. The result is healthcare inflation that consistently outpaces general inflation. And American families feel the consequences every January when their premiums rise once again. With that, we will take our first break, and when we come back, we will continue discussing the price crunch. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're doing a 5-part series on healthcare reform. We're in the second episode, Price Reform. Before the break, I argued that America's healthcare spending problem is fundamentally a pricing one. We don't simply consume more healthcare than other developed countries. We pay dramatically more for nearly everything. Now let's talk about why that happens. This one word in Part 6 explains a great deal of it: consolidation. Over the last 3 decades, healthcare has experienced an unprecedented wave of mergers and acquisitions. Hospitals bought physician practices. Hospital systems merged with one another. Health plans bought health plans. Specialty groups combined into mega groups. Private equity entered healthcare in force. Large national physician organizations emerged. Some of this consolidation produced genuine benefits. Larger systems can spread administrative costs over more patients. They can invest in expensive technology. They can better coordinate care across multiple settings. They can negotiate more effectively with suppliers and health plans. These are legitimate advantages, but there's another ugly side to consolidation. When one health system owns most of the hospitals in a metropolitan area, and perhaps many of the physician practices as well, competition begins to disappear. When competition disappears, prices almost always rise. And that's exactly what has happened. Today, many communities have one dominant health system, at best two. Health plans negotiating contracts don't have many alternatives. Employers don't have many alternatives. Patients often don't have many alternatives. The dominant systems effectively say, if you want our hospitals in your network, here are our prices. Health plans try to push back. Providers push harder. Eventually, the plans give in because they need those hospitals to satisfy network adequacy requirements and to remain competitive. Who pays? Employers, families, taxpayers, consumers. Ultimately, every one of us. Part 7, the illusion of negotiation. People often assume aggressive negotiations between insurers and providers naturally lead to efficient prices. Sometimes they do, but many times they simply determine which side has more leverage. That's not the same thing as determining the appropriate price. Think about Medicare for a moment. Traditional Medicare doesn't negotiate every hospital contract individually. It establishes payment methodologies. Providers know the rules, plans know the rules, patients know the rules. No one is surprised. Now, I'm not suggesting Medicare's rates should automatically become the rates for every payer, but Medicare demonstrates an important principle. A healthcare system doesn't require millions of separate negotiations to establish rational prices. Many developed countries use national or regional fee schedules across all payers, some of which result from negotiations. Hospitals know what they'll be paid. Physicians know what they'll be paid. Patients know what the services cost. Competition doesn't disappear. It simply shifts. Instead of competing based on negotiating leverage, providers then have to compete on quality, patient experience, access, innovation, and efficiency. These are the things we should want providers to compete on, not who has the biggest legal department or the greatest market power. So part 8, a better way, uniform pricing. This brings me to one of the cornerstones of my proposal. I believe America should generally move toward a national and regional pricing framework that applies across all major lines of business. It could include setting fee schedules as well as negotiations. Now, before some of you panic, let me explain what I mean. This is not government-run hospitals. This is not nationalizing healthcare. Private hospitals remain private. Private physician practices remain private. Private health plans remain private. Competition remains. Innovation remains. The difference is that everyone begins from the same rational pricing foundation. Again, either through setting schedules or negotiations. The idea isn't radical. It's already how many successful healthcare systems around the world operate. Even here in the United States, traditional Medicare has demonstrated that standardized fee schedules can create predictability and administrative efficiency. Health plans could still reward providers who deliver exceptional outcomes. Value-based payments would continue. Performance incentives could continue. Innovation payments could continue. But the extraordinary variation in prices would largely disappear. Imagine what that means. No more employers paying double when another employer pays for identical services. No more hospitals charging 10 times as much simply because they dominate a market. No more consumers wondering whether an MRI costs $500 or $5,000. Price variation would narrow, predictability would increase, administrative costs would fall, transparency would improve dramatically. Now, critics especially those in my own Republican Party, will argue that I am some sort of crazy liberal advocating for government price fixing. After all, they argue, you would be impeding the free market. Well, as I have alluded to above, we do not have a free market in healthcare. It is anything but that. And there is a legitimate reason for the state to intervene when markets do not operate appropriately. And as I also stated, negotiations can occur at state and regional levels to make prices fair and equitable for all parties. Market forces can help drive these discussions to arrive at price. Part 9. Site-neutral payments. While we're discussing pricing, let me address another reform that I believe is long overdue. Site-neutral payments for hospitals. This sounds technical. It's actually common sense. Suppose you receive the exact same infusion therapy. If you receive it in a physician's office, it may cost one amount. If you receive it in a hospital outpatient department, the price may suddenly become dramatically higher. Why? Not because the drug changed, not because the physician changed, not because the outcome changed, not because there was higher acuity, simply because of where the service occurred. Hospitals frequently receive higher reimbursement and often add facility fees for services that could easily be delivered elsewhere. Consumers rarely understand this. Many don't even know the distinction exists. I believe identical services should generally receive identical reimbursement regardless of where they're delivered. If the service truly requires a hospital, pay appropriately. But if it can safely occur in an ambulatory surgery center, physician office, or even in the patient's home, the payment should reflect that reality. And if it is done in a hospital outpatient, the hospital outpatient would receive the reduced payment. Site-neutral payments would save tens of billions of dollars every year for consumers, employers, and the government. More importantly, they would encourage care to migrate toward the most efficient setting without sacrificing quality. That's good for patient, that's good for employers, that's good for taxpayers. Part 10, transparency is necessary, but it isn't enough. Now you may be thinking, Mark, haven't we already tried price transparency? Yes, we have. Hospitals now publish enormous files listing prices. Health plans do the same. On paper, transparency has improved. In practice, very little has changed. Why? Because transparency without understandable information isn't really transparency at all. Dumping millions of lines of pricing data onto a website doesn't help consumers as much as I support the move. People need meaningful information. They need to know, what will this procedure actually cost me? How does this provider compare on quality? Is there another facility nearby that's equally good but substantially less expensive? Transparency should empower consumers. Today, it mostly overwhelms them. Price reform must include information that ordinary Americans can actually use. Part 11, value should replace volume. Finally, price reform isn't simply about lowering prices. It's about paying for value. We've talked about value-based care for years. We've made progress, but we haven't gone nearly far enough. Providers who consistently produce excellent outcomes should be rewarded. Providers who reduce complications should be rewarded. Providers who keep patients healthy should be rewarded. Providers who coordinate care effectively should be rewarded. The current system often rewards volume instead. More procedures, more admissions, more imaging, more interventions. Sometimes those services are absolutely necessary. Sometimes they clearly aren't. A smarter pricing system encourages better outcomes rather than simply more activity. That's the direction America needs to move. With that, we will take our second break, and when we come back, we'll tackle one of the most important and controversial parts of price reform: prescription drugs, pharmacy benefit managers, reference pricing, and why I believe these reforms, combined with everything we've discussed today, could save the American healthcare system hundreds of billions of dollars each year while improving quality and affordability. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back. My name is Marc Ryan, and I hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We've been talking about my views on healthcare reform as we move deeper into the 2026 midterm cycle, and specifically about why I believe price, not utilization, is the central driver of America's healthcare cost problem. We talked about why prices vary so dramatically and why that isn't just inefficient. It's structurally embedded in how we pay for care. We also discuss consolidation, site-neutral payments, transparency, and why value has to replace volume. Now, I want to turn to one of the most contentious areas in the entire system, Part 12, prescription drugs, the most visible price problem. If there is one part of the healthcare system that Americans instinctively understand as broken, it is drug pricing, and for good reason. Two patients with the same condition can pay radically different prices for the same medication. One patient with insurance pays $25 at the pharmacy counter. Another pays $300 for the same drug if uninsured. Someone with insurance can still pay more than cash price in some cases. And then we have the broader question. Why does a drug that costs a few dollars to manufacture end up costing hundreds or thousands of dollars in the United States a month? The answer is not simple, but it is not mysterious either. It is a function of patents, market exclusivity, fragmented purchasing, rebate systems, and a supply chain that has become increasingly opaque. Part 13, the role of pharmacy benefits managers or PBMs. No discussion of drug pricing is complete without addressing pharmacy benefits managers. PBMs were originally created to help manage drug benefits, negotiate discounts, and reduce costs for payers. In many cases, they still do. But over time, the system has become more complex. Rebates, spread pricing, formulary placement incentives, and administrative fees have created a system where the list price is often not the real price, the rebate is not always visible to the consumer or passed through, and the patient often pays based on a distorted gross benchmark that ignores any rebates earned by the PBM from brand drug makers. This disconnect between list price, net price, and out-of-pocket costs has eroded trust in the system. It also makes it very difficult to understand whether savings are actually reaching employers, taxpayers, or patients. Some of the most significant reforms in recent years, both in legislation and executive action, have focused on increasing transparency and pushing toward more direct pass-through of discounts, and actually even ending gross and rebate pricing in favor of net pricing. That direction is right, but it's not sufficient on its own because complexity itself has become a cost driver. Part 14, the Inflation Reduction Act, a turning point. We should acknowledge something important. The Inflation Reduction Act's Medicare drug pricing provisions represent a fundamental shift in U.S. policy. For the first time, the federal government, under the Biden administration, engaged in direct negotiation of certain drug prices in Medicare. That moves the U.S. closer to what many other developed countries already do in some form, using centralized purchasing power to control costs for high-impact drugs. Is it perfect? No. Is it controversial? Absolutely. But it establishes a precedent, and that precedent matters because once a system begins to recognize that drug prices are not purely market determined in practice, it becomes possible to design more coherent pricing frameworks across the entire system, not just Medicare. Part 15, the missing piece, extending rational pricing across markets. Here is where I think the real opportunity lies. We should not treat Medicare drug pricing reforms as a standalone policy. Instead, it should be the foundation for a broader alignment of pricing across Medicare, Medicaid, exchange markets, employer coverage, and potentially other public programs. The goal is not identical pricing everywhere. The goal is rationalized drug pricing across the system so that extreme disparities are reduced and transparency is improved. Right now, the same drug can have multiple different effective prices depending on the payer, the rebate structure, and the contracting arrangement. That fragmentation creates inefficiency and distorts incentives across the entire system. Part 16, reference pricing and international signals. One approach that has gained attention is international reference pricing. The idea is straightforward. Instead of allowing unlimited pricing variations, anchor drug prices to a set of comparable international benchmark nations. Many peer nations already use versions of this approach as part of their broader pharmaceutical purchasing strategies. The United States has historically resisted this model for one primary reason: concerns about access and innovation incentives. And those concerns are not trivial. America leads the world in pharmaceutical innovation in many categories. We need to be careful not to undermine that strength. But we also need to recognize that uncontrolled pricing does not automatically produce better innovation outcomes. A balanced system can support both innovation incentives and affordability and access. The question is structure, not ideology. I give a great deal of credit to the Trump administration for building on Medicare drug price negotiation, negotiating discounts with brand drug makers, and pursuing international reference pricing pilots in Medicare and Medicaid. No other president has done this. Trump has done more for moving price in America on drugs than any president. Part 17, consumer exposure and misaligned incentives. One of the most underappreciated issues in drug pricing is how rarely consumers are exposed to the true cost of drugs in a meaningful way. In most cases, patients do not choose the drug, patients do not see the full price, patients do not know the net cost after rebates, and patients often cannot easily compare alternatives. That removes normal market pressure. In a functioning market, consumers respond to price signals. In healthcare, those signals are often blurred or absent. That is especially true in drug markets where insurance design shields patients from true costs in ways that are both protective and distortionary. The challenge is not to shift excessive burden onto patients. The challenge is to design systems where low-cost, high-value drugs are encouraged, high-cost alternatives require justification, and savings actually flow through to patients and employers. Part 18, aligning incentives across the system. Drug pricing reform cannot be isolated. It has to align with the broader price reform framework we discussed earlier. That means site-neutral payment principles where applicable, greater transparency in net pricing, reduced administrative complexity, and payment systems that reward outcomes rather than volume or formulary manipulation. Because ultimately, drug pricing is not about pharmacy benefits. It is about how the entire healthcare system allocates resources. When drug spending is inefficient, it affects premiums. It affects employer costs, federal spending, patient adherence, and it affects long-term outcomes. Part 19, fraud, waste, and administrative complexity. We also cannot ignore another reality. A meaningful portion of healthcare spending is not driven by medical need or innovation. It is driven by administrative overhead, inefficient billing, wasteful utilization, fragmented payment processes, and in some cases, outright fraud. I always use this example. About 25% of our spending today in healthcare each year is for fraud, waste, and abuse. No single reform eliminates any of this, but pricing simplification helps. When prices are more standardized and transparent, billing becomes simpler. Auditing becomes easier, disputes decrease, administrative costs fall. That alone produces meaningful savings without reducing access to care. With that, we will take our third break, and when we come back, we'll give you some closing thoughts. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back. My name is Marc Ryan and hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We've been talking about my views on healthcare reform as we move deeper into the 2026 midterm cycle, and specifically about why I believe price, not utilization, is the central driver of America's health cost problem. Part 20, the big picture. If we step back, what we are really talking about is this. America does not need to eliminate private healthcare. It does not need to eliminate public programs. It does not need to radically restrict innovation. What it needs is coherence, a pricing system that is more predictable, is more transparent, reduces extreme variation, rewards value over volume, and aligns incentives across payers. That is what price reform is fundamentally about. Not squeezing providers, not reducing access, but rationalizing a system that has become increasingly disconnected from any coherent pricing logic. Looking ahead, in episode 3, we are going to shift from prices to something equally important, but often overlooked in policy debates. We're going to talk about why America is so focused on utilization management, prior authorization, claims review, and administrative gatekeeping, and why I believe that focus is fundamentally misplaced, because the real opportunity is not simply controlling what care gets delivered. It is improving the health of populations so that less crisis care is needed in the first place. We will talk about primary care, prevention, chronic disease management, social determinants of health, and why the United States underinvests in all of them. That is where we go next. That's it for today's episode of the Healthcare Labyrinth Podcast. Thanks for listening. If you enjoyed today's episode, be sure to subscribe and share it with colleagues interested in healthcare policy. You can also read the companion blogs on the Healthcare Labyrinth blog site, along with the other installments in this series, published on May 26, May 28, June 4th, and June 12th. And if you want to go deeper, my book, The Healthcare Labyrinth, is available in print, ebook, and audio formats through major booksellers and at healthcarelabyrinth.com. Until next time, stay curious, stay skeptical, and keep navigating the healthcare labyrinth with me. We will find our way out together. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.